Dr. Benjamin Gaston is the Billy Lou Wood Professor of Pediatrics at Indiana University School of Medicine, where he serves as the Vice Chair for Translational Research. He earned his bachelor's and medical degrees from the University of Virginia, and after residency and a tour of duty in the U.S. Navy, he received fellowship training in pediatric pulmonology at Boston Children's Hospital under the mentorship of Dr. Jeffrey Drazen. Dr. Gaston has over 230 publications and 15 patents. He's been continuously funded by the NIH for over 25 years, currently serving as the principal investigator on a program project grant aimed at asthma. He's co-founded several active companies focused on developing novel approaches to managing respiratory disorders. He also continues to treat children as a pulmonologist at Riley Hospital for Children. Dr. Gaston will tell us about his successes in developing a potential life-saving treatment for respiratory depression. So please join me in welcoming Dr. Gaston.
Thanks very much, Seth. Really appreciate it. It's such an honor to be here and see so many distinguished friends and colleagues, and to provide you with some details about what it's like to be a Harrington Scholar, and to give you some idea about the course of drug development. Let's advance here. A problem that my research group addresses is this. That of chronic respiratory depression, which is really solved by mechanical ventilation for the most part. What kinds of patients need to be on a mechanical ventilator for a long time? Well, a few examples are the following. One is pneumonia of various kinds, most notably COVID-19. And we all remember that the United States virtually ran out of ventilators because people were on the ventilator for so long, and so many people were on the ventilator. Trauma, including battlefield trauma, chronic lung diseases, extensive and painful surgeries, major burns. Many of these things that you're familiar with lead to a long course of painful medical intervention, and the patient needs to be on the ventilator for all of that time. There are approved stimulants for the heart that increase cardiac output. They're used in the ICU every day. So if your heart is failing, you have cardiac failure, there are medicines that you can use. Not so much so for respiratory failure. There are really no safe and effective respiratory stimulants available for routine use. And that's why we are focused on developing new respiratory stimulants. Just go back here. So the problem is this, fundamentally. The longer you're on a ventilator, the more likely you are to die. Whatever the cause, patients develop pneumonia, weakness, they develop lung injury, air leaks, a variety of things that daily increase the risk of dying as you're on the ventilator. And to give you an example of this, it's not quite so abstract. Imagine that you know someone who has had a major trauma, falls off a cliff, or develops a severe pneumonia like COVID. When that person can't breathe and is really uncomfortable and desperate for air, we will put them on a ventilator. And that solves the problem temporarily. But as I pointed out to you, many people who are on a ventilator just don't get off. And unfortunately, the outcome, the longer you're in the ICU and on the ventilator, is often death, no matter what the age of the patient, no matter what the underlying condition. And in today's world, many patients with respiratory therapy who don't survive are part of the things that we read in the news every day, the tragic warfare, pandemics, so many things that we see that result in prolonged ventilator course associated with bad outcomes. So where does a respiratory stimulant come in? Well, here is one of many examples, and this is some work from our lab. And I'll just give you an example of how this works. So say you have a patient who's very uncomfortable, can't breathe. We sedate that patient, make him comfortable, and put him on a ventilator so he can breathe. Then once things are better with his lungs or her lungs, we aim to get him off the ventilator. And what happens in that situation is often the patient wakes up, is very uncomfortable, combative, pulls off surgical dressings, and is really a tremendous danger. So we wind up resedating the patient with narcotics, benzodiazepines, anesthesia, so forth. And then the patient is happy, the nurse is happy, the family is happy, but it's not a good situation because that patient still is at risk. The longer they're sedated and requiring ventilation because of the sedation, the more risk they are for dying. So each of these is a potentially fatal complication, a fatal situation. So what was the solution that Harrington Discovery Institute has helped us to put in place? So a respiratory stimulant lets the patient breathe off the ventilator while comfortably sedated. That's the goal. Here's an example from a rodent study. So these are rats, and if you give the rat a drug that depresses respiration, in this case it's fentanyl, but it could be a variety of others.
Your slides are 1 out of sync.
Oh, they are? Oh.
We're seeing the previous.
Oh, okay.
Not seeing the data.
Oh, thanks, Bill. Yeah. Okay, great. How's that? All right, thanks. And so if a patient has respiratory depression, or in this case the rat has respiratory depression, rather than putting the rat or the patient on the ventilator, the idea is to give the drug. In this case, the drug normalizes minute ventilation, completely gets rid of the respiratory depression. You can even overshoot and cause the animal to hyperventilate with no ventilator needed. This work has been validated now in rats, mice, and in dogs in 3 species. Remarkably, this compound, and this class of compounds, our lead compound is Adaleric 0199, which I'll talk about, improves oxygenation in an animal that has severe respiratory depression to the point of death without the animal needing to be on the ventilator, and that's shown in the blue lines here. Compared to the control solutions. Also, the compound in this class of drugs permit complete pain relief without reversing respiratory depression. So using 2 different kinds of tests and a number of species, we're able to show that, for example, if you're requiring morphine or fentanyl, the pain relief that those drugs provide is not inhibited at all by our drug. Our drug has a completely novel mechanism of action that doesn't involve the opioid receptor. It works at the level of the carotid body through a potassium channel. It sends signals from the carotid body to the brain, telling the brain to breathe deeper and to breathe faster, both of them being mechanisms of respiratory stimulation. This work began with NIH grants to the co-founders, more than $16 million in grants. The Harrington Advising and Awards enabled the company to really get off the ground. Company funding provided, there's now equity funding the company in addition to a new SBIR. Harrington Advisors enabled us to translate this discovery into potential new drug entity. The choice of and funding for an affordable CRO was the work of the Harrington Advisors. Market analysis, program management, advice about pharmacology, advice and funding to support preliminary manufacture, advice and funding to support toxicology. Data that enabled us to successfully to compete for the SBIR and to get other funding. Particularly, I'd like to thank Larry Olenoff and Bill Murray at different stages of the development of this project, but so many people in this room have been helpful. So Adaleric 0199 represents a transformative technology. No one has ever seen anything quite like this before. There are many possible clinical indications. The lead indication will be, as I discussed, getting people off the ventilator, a shorter time on mechanical ventilation. But later indications could include safer and faster extubation after surgery, prevention of respiratory failure in high-risk patients who require sedation, reversal of respiratory depression caused by polydrug overdose, acute use in the battlefield and ambulance, treatment of a range of causes of respiratory decreased drive to breathe, like COPD, as well as safe treatment of pain in conjunction with these compounds, for example, in oncology. And so with that, I'd like to thank all of those who made this program possible, but particularly the Harringtons and the Harrington Discovery Institute, and the NIH, my lab group in Indianapolis, the lab group here in Case Western who's still working on this. So thank you very much for your attention and support. And my email is there, so send me a note if you have questions.